Over to you, Dr. Kingston.
Thanks so much for having me, and thanks to Migraine Canada for all the work they've been doing at educating people about migraine and other headache disorders, and specifically today for Cluster Headache Awareness Day for highlighting a non-migraine headache disorder, which is still a very important one, as I hope I'll convey to you. Just a couple of notes. If you saw this last year, the content is not a whole lot different. There hasn't been a great deal of updates since last year, but that's okay. It's always a good topic to speak about. And in terms of questions, of course, I won't be licensed to give any specific medical questions that you may have about yourself if you're inquiring about yourself, but some general questions are just fine. And we'll do our best to get to as many as we can. So I have a couple of disclosures in terms of conflicts of interest, but none of them are in direct conflict to anything that I'm going to be speaking with you about this evening. So I want to talk first about what cluster headache is. So we know that cluster headache is a syndrome of one-sided headaches that are what we call side-locked. When we use the word side-locked, it means it generally only stays on one side and does not switch to the other side of the head. For example, we talk about migraine as being a unilateral, or unilateral meaning one-sided headache, but with migraine, it quite often will change sides, whereas with cluster headache, it typically remains on the same side. It's also associated with features that we call autonomic features. And when I say autonomic features, that's the part of the nervous system that causes automatic reactions like tearing, like nasal congestion, like redness of the eye, things that are beyond our own conscious control. They have been termed suicide headaches because of the severity of the headaches that come with cluster headache. And it's often been described as being the most painful condition known to human beings. It's generally what we call a primary headache disorder. So as a rule, headache disorders are divided amongst other ways, but into primary and secondary headache disorders. A secondary headache disorder means there is probably something underlying that we can see on a test or a scan that may or may not require treatment. That is a direct cause of the headache, and the headache would not be present if that other problem was not there. A primary headache disorder is a headache that sort of just happens, usually for genetic reasons or reasons that we don't fully understand, depending on the individual headache disorder. It's also further subcategorized, cluster headache specifically, but also other disorders like migraine, into what we call episodic and chronic. Generally speaking, an episodic cluster headache is somebody who has cluster headaches that meet criteria for cluster headache that have a reprieve for at least 3 months of the year where they do not have those headaches. Someone who has chronic cluster headache does not have even a 3-month period of breaks where they do not have headaches at all. So you can see that just by that and hearing that very fact, that cluster headache is by definition a more disabling form of the disease. So there can be secondary headaches that mimic cluster headache, and that's why we often recommend some baseline testing when you get a new diagnosis of cluster headache, which we don't always do with every other headache disorder. For example, we often don't recommend any testing when someone has migraine, depending on the scenario. This is sort of the way that we diagnose headache disorders using this guide called the International Classification of Headache Disorders. And I won't go through this criteria in excruciating detail, but I'll explain a little bit about how we come to this disorder. So generally speaking, we say that it has to be a severe or very severe headache that occurs on one side of the head. And there are specific timelines that we usually adhere to in terms of making that diagnosis. And that's why tracking the duration of your headache is actually really important to actually help your doctor come to the right diagnosis. And generally speaking, there should be at least 2 autonomic symptoms that happen with that headache on the same side as the pain. And those autonomic features can be anywhere from watery eyes, which we call lacrimation, redness of the eye, nasal congestion or runny nose as well, eyelid swelling, and pupillary abnormalities, like a pupil that's too small or too big during the headache episode. And the frequency with which they occur is also an important way for us to make an appropriate diagnosis. So each individual headache could happen as often as 8 times a day or as little as 1 every other day while someone is in a cluster headache period. And as I mentioned, we do know that episodic and chronic cluster headache are a little bit different. And thank goodness most people with cluster headache have episodic cluster headache. which is great because there are also more treatment options for episodic cluster headache, as I'll mention. So we spoke a little bit about those autonomic features, and there are some that are more common than others, and sometimes they can be a little bit more subtle. So lacrimation or a watery eye is the single most common feature we see with cluster headache, and about 75% of people who have cluster headache will have this during an individual attack. What we call a conjunctival injection or a red eye occurs about 60% of the time, and then followed by a nasal congestion. There is also an entity that we call a Horner's syndrome, and that's characterized by a droopy eyelid, a small pupil, and a change in the sweating pattern on one side of the face. And there are lots of things that can cause a Horner's syndrome that we might have to go looking for, but actually, interestingly enough, frequent attacks of cluster headache is a reason somebody could have something called a Horner's syndrome. And that can sometimes last in between attacks when it's been going on for a very long time. Interestingly, unlike other headache disorders, we know that restlessness or agitation are particularly important, a particularly important feature in cluster headache. In fact, when you poll people, there's only about 3% of people who meet criteria for cluster headache that are actually able to sit still during an individual attack. Commonly reported are people who need to rock back and forth, pace around the room. Sometimes you hear people about banging their head against the wall, crawling on the floor, jumping in the snow. It's sort of a feeling of almost desperation that comes with having a cluster headache episode. If you contrast that to a disorder like migraine, where people are disabled in bed, lights off, everyone tells everyone to leave them alone, it's still a very disabling headache disorder, but the behavior that comes with it is quite different. And I think all of these things just show you how complex it is to make these diagnoses and why it does take both a proper history from a physician to come to the right diagnosis. And why that's important is there's actually several other disorders that look a little bit like cluster headache. So knowing for sure about the timing, how many episodes are occurring, how long it's been going on, what are associated features, can really help us determine whether it really is cluster headache, a related disorder, or something else entirely. So the other things that we see that make cluster headache so interesting is it's been noted that there's what we call circadian periodicity, which means there seems to be a time of day where it's very clear that it happens each time. There's a handful of people who will also say that they have, like they could set their watch by the time they're going to get their headache. They know exactly when it's going to happen. Often it wakes them from sleep. I'll show you a little graph about the most common times to actually have an attack of cluster headache. And what we call a circannual periodicity, which is like a seasonal predilection. So there are certain seasons where it's more likely to happen. And in fact, we're in one now. So it's appropriate that Cluster Headache Awareness Day occurs in March because the spring is one of those seasons where it's most common. In fact, I think I've had 3 patients just this week contact my office saying that they've had a recurrence of their headache. So I wasn't terribly surprised to hear from them this week. Many people with cluster headache will describe a feeling of a foreign body in their eye, like almost like there's something stuck in there that they can't quite get out during a cluster headache episode. And when I say migrainous feature, so that is a feature that we typically see with a migraine disorder, can occur sometimes in people with cluster headache, but often those features are one-sided on the same side as the pain. The most common being sensitivity to light, which we call photophobia. Some studies report that sensitivity to light on the same side of the headache can occur as often as 90% of people with cluster headache. And I think there's a couple of things to bear in mind here, and that's that because it's more common in men, some women who experience sensitivity to light with cluster headache may get misdiagnosed as having migraine. This is an actor's depiction of some of the ways that people with cluster headache have described their symptoms on this slide here. So I mentioned before that it's often striking how much it occurs at the exact same time of day. And there's a few reasons for that, or at least we think there is. And there may be some genetic underlying causes that actually lead to that. There still is a lot of work to do on exactly what those are, but there's been some specific genes that have been linked to cluster headache that make it a little bit more interesting. And some of those are genes that are also responsible for the production of a chemical called PACAP. And we know that chemical is one of the important drivers in other headache disorders, such as migraine. Most time to actually experience an attack of cluster headache. This is a graph demonstrating exactly that. So this was a study that was undertaken looking at multiple questionnaires across the world and finding the single most common times to actually experience a cluster headache. And here you can see a very clear peak at 2 a.m. In terms of the time of year, in terms of the time of day, specifically because a lot of them occur at nighttime, this can lead to essentially a fear of going to sleep or a fear of getting a headache. And there's actually a term for this. A fear of getting a headache is called cephalalgia phobia. And this can actually lead to sleep disorders if one does not already exist from having interrupted sleep from the cluster headache itself. But this can lead to an advanced phase sleep disorder. It can lead to psychological comorbidities like anxiety and depression. And the reason why this happens is not entirely clear, but it may be an effect of sunlight, as it seems to be a little bit less common in equatorial countries compared with northern and southern countries. In terms of the time of year, in North America, it tends to be most common in the fall and the spring. And some people will describe that it happens twice a year, sometimes once a year, and sometimes it skips years. Sometimes it only happens every other year or every 2 to 3 years. I have one person who only seems to get it about every 5 years. And why there's that clear disparity amongst different people, I think is yet to be determined. This is that same study that looked at people across the world and the times of year where it's more likely to happen. This is specifically to North America, this graph, but this shows a clear peak right around now, and then another peak in the fall, specifically in October being the most common. And that's certainly what I observe in my clinical practice as well. So there are other important things to consider when we talk about cluster headache, and this may resonate with some people who know someone or perhaps have experienced this themselves, and that's that it gets missed. So the average time to actually come to a correct diagnosis from the first symptom is about 5 years. And only about 21% of people actually receive the correct diagnosis at the time they present to their doctor. The other thing to mention is that people can have suicidal thoughts when they actually have a cluster headache episode because of how severe it is. In fact, about 55% of cluster headache patients have contemplated suicide at some point during a cluster headache attack. Interestingly, we know alcohol can trigger an individual attack, but it seems to only be a trigger when someone is in their cluster headache cycle. So if you have episodic cluster headache and it's March, you may want to avoid alcohol because that may actually bring on an attack. But if you never get a cycle, let's say in the summertime, and have a drink of alcohol, it may do nothing to actually trigger an attack. And for whatever reason, we found that beer seems to be a more potent trigger than other forms of alcohol. Whereas, historically you hear that people who have a lot of migraine may avoid things like wine. About 75% of all attacks are less than 60 minutes. And that's tricky. If you think about the kinds of treatments that we use for any medical condition, any pain condition, most of the treatment options that we have are oral. Oral treatments take time to work because they have to be ingested, they have to be dissolved, they have to be digested, they have to get into your bloodstream, and then they have to get to the proper concentration in your blood to actually become effective. And often that takes an hour in and of itself. So treating cluster headache with oral medications on an as-needed basis often really doesn't work, simply because of the duration of the individual attack. And only about 15% of people who have cluster headache will ever experience a headache on the opposite side of their head. So the overwhelming majority of people who have cluster headache really only ever have it on one side. So we know that about 4 in 1,000 people in the world have cluster headache. So it's, you may hear about it being referred to as a rare disorder, but the truth is it isn't. Other diseases that have a similar frequency are things like multiple sclerosis and Parkinson's disease. And if you look, across the world, across whatever city you live in, you can probably find a pretty easy access to a multiple sclerosis clinic or a movement disorders clinic that treats Parkinson's disease. But there really aren't very many specialized, or really any specialized clinics that are dedicated specifically to cluster headache. And there are reasons for that too that I will go over in terms of why people get missed. So we know that it's more common in males compared to females, we think, but there's other issues at play here. There may be a lot of misdiagnoses here. It may be that women present a little bit differently than men. So I think we're learning a little bit more about the epidemiology of cluster headache from that perspective as well. It rarely happens in pediatric populations, but when it does, the be quite a similar ratio from males to females, but it's that sort of peak productive years between the ages of 20 and 50 where it seems to be a disparity and there are more males affected. Because of late diagnoses, patients might feel normal for long periods of time in between. So for example, I mentioned before that some people may go a year in between attacks, or maybe even 2 years between attacks. And because of this, it's really hard to get data on this disease. It's really hard to capture someone who might have 6 weeks of the year where they're affected, get them, they have to, track the baseline number of headaches that they have before they start a treatment, before a study gets enrolled, and then look to see if a medication makes a difference. That's really hard to do when you have a thing that can last for such a brief period of time, and one that often doesn't make it to the right people for the proper diagnosis. So that's why there's a lack of evidence, and that's why there's a lack of studies to really show what things work and why they work. So common misdiagnoses. So the single most common thing that someone would be misdiagnosed with would be migraine. Sinusitis, believe it or not, and that's probably to do with the nasal symptoms that can come along with always raise an eyebrow when I hear the word sinus headache, because it probably isn't real in most people, and it's probably either migraine or cluster headache depending on how they're presenting. And believe it or not, dental issues sometimes get sometimes someone may be misdiagnosed as having dental issues instead of cluster headache. That one I find a little harder to believe, but it does happen. So here are some issues as to why people get missed. So first of all, I mentioned that the light sensitivity that can occur may be only one-sided, but it can lead to an inappropriate diagnosis of migraine. The autonomic symptoms that I talked to you about may be mistaken for allergy symptoms, sinus symptoms, and we think that women may have slightly unusual attacks in that their attacks may be a bit longer than our standard set of criteria compared with men, and they may be more likely to have features that are that have migraine that may mistake them for having migraine compared with men. And that may also be because migraine is such a common disorder in the general population, with 1 in 7 to 1 in 8 people worldwide having migraine, that there are definitely people out there that have both conditions. And that can lead to a very difficult way to kind of factors, physician factors. So the word cluster can be misleading. So for example, there are lots of patients who have migraine who believe they have cluster headache because their headaches tend to group together or occur on multiple days in succession. And we'll often hear the word, well, I have cluster migraines, when that really is not a diagnosis. It's migraine that's occurring on multiple back-to-back days, but that's not a cluster migraine. And then, as I mentioned before, some people just truly have both diagnoses. So why does cluster headache happen? So we know that it occurs probably on a spectrum with other disorders that are similar, and collectively those groups of disorders are called trigeminal autonomic cephalalgias. We call them TACs for short. And there are several of these. There's 4 that are sort of well described, and there's some that are rare that may or may not truly exist as individual entities, but they probably represent a spectrum of disease. And where they differ is between the timing of the individual headache, the duration of the individual headache, and do they have periods of reprieve in between? Like what's happening between the individual headache? Is the headache truly gone, or is there a baseline headache there that never quite goes away? So those are all things that we really need to consider when we're coming to a proper diagnosis. So the reason why it happens is a little bit poorly understood. It's likely due to an interplay between several systems in the brain. From the high cervical spine and the trigeminal nerve. And we know that the thalamus and hypothalamus almost certainly have an important part in the generation of cluster headache because of the autonomic symptoms that get experienced, and probably because of the timing of day, the seasonal predilection is probably linked to the hypothalamus as well. Altogether, the relationship between these is called the trigeminal autonomic reflex. So is cluster headache always a primary headache disorder? I will just put a caveat in front of this and say that if someone meets perfect criteria, there are no red flags, nothing is happening otherwise, I always put a little bug in someone's ear saying, you know, we sometimes investigate to look for certain things, but most of the time we don't find something. And to make a diagnosis of a headache disorder, it really is contingent upon the history. It's very rare that we find a test that tells us something. So the truth is there are no tests for headache. You can't make a diagnosis of headache with a test. You can confirm certain diagnoses with testing depending on the individual headache disorder, but it really is something we diagnose based on talking to somebody and examining somebody. So most cases, certain blood clotting problems like a venous sinus thrombosis, they have been reported. It's very rare for that to be a cause. And if it's been going on for years and years and years, something like that is almost never the cause. Really what we look for causes like this, if someone has a brand new onset of symptoms that look just like this. Some people have a small little lesion in their pituitary gland. It's usually a benign lesion, but sometimes those lesions can actually secrete hormones. And if there is some hormones being secreted, sometimes if we treat the hormonal imbalances, the headaches can actually improve. So that's one thing we definitely go looking for in people who have cluster headaches. And there is even reports of people having headaches similar to cluster headache after a severe head injury, but that's quite rare. So we know that the amount of people who have a pituitary lesion, like I mentioned, it's not exactly clear, and it's not clear whether it's incidental or whether it's really the cause. There are certainly lots of people across the world who get imaged for other reasons, and we find they have a small little lesion in their pituitary gland. Most of the time it amounts to absolutely nothing, and those people may not even have headache. So why in some people could it be related and why is it unrelated in others? I think that's something that's yet to be determined. And there are lots of things you can find in someone's pituitary, and which ones are potentially causative and which ones are completely bystanders, I think is something that we still have to do a lot of work on to figure out. Headache are older at the age of onset, they often have an abnormal examination. So there's something that will cue your doctor when they're examining you to say, that's not right, we need to do some testing. Sometimes the actual characteristics of the headache don't fully match our criteria. So there's something that's just off when you're listening to someone's story. And then we may see something abnormal on their systemic examination. Like we may see actual things when we examine them that point us towards hormonal imbalances, as I mentioned before. Out of all of the 63 cases in this one particular study that I'm referring to, about 22% of them were attributable to a pituitary problem. And most of those were due to a small growth on the pituitary gland. The good news is when we find them, and if they are, we believe they're the cause, sometimes treating them, usually with medication, if it is one that causes hormones, can actually help. It's rare that surgery to actually remove I'm sorry for the feline interruption behind me. This may not be the only time it occurs. We don't know exactly why pituitary lesions or pituitary disruptions can cause cluster headache, but we think it probably has something to do with the interruption between the hypothalamic tracts and their relationship to the trigeminal nerve that I mentioned before. So it interrupts that trigeminal autonomic reflex. And when we do find something, it's usually on the same side as the pain. So if you look at across the board, if you're going to, let's say, an endocrinology clinic or a neurosurgery clinic, and you look at everyone who has some kind of pituitary problem or pituitary growth, about 10% of them will have attack-like headache. Whether it meets full criteria for cluster headache or not, I think is yet to be determined, but that was a study back in 2005. Whether they were severe enough to require treatment is something that's unknown. So this is my recommendation. Unfortunately, there are not great guidelines on exactly what we should be testing and when we should be testing it. This is something that I'm actually working on with a couple of colleagues at coming to make a Canadian guidelines on evaluation and testing for cluster headache. So stay tuned. Hopefully that will be available in the next couple of years. In my opinion, all people with a new diagnosis of cluster headache should have some kind of brain imaging, usually looking at the pituitary gland. And in the right scenario, looking at their blood vessels can be important too. Consider hormonal testing, as I mentioned, specifically things like prolactin, which would be the most important one, and sometimes testosterone, particularly in male patients. And a sleep study, and that can be important for a couple of reasons. So we know that out of that when they have episodic cluster headache. And so if someone is getting a sleep study, I think my connection is just unstable here. Sorry if I timed out there for a second. So if someone is getting a sleep study, it's actually more helpful for them to have their sleep study while they're in a cluster headache cycle. And interestingly enough, when someone does have sleep apnea and cluster headache, their symptoms often improve once that sleep apnea is treated. And sleep apnea in and of itself is not benign. We know that sleep apnea, when untreated, is a risk factor for high blood pressure, heart disease, and stroke. So actually getting that looked at symptoms. Most people, actually pretty well all people, need some kind of abortive or what we call rescue treatment. That is to say a treatment for each individual headache when it happens to kind of get your day back when it occurs. And then sometimes we use transitional treatment. That's more for people with episodic cluster headache that we may use transiently for a few weeks, whereas preventive treatment really refers to something that's taken for months or longer. So as I mentioned before, because of the nature of cluster headache, we don't have very many large scale studies. The evidence for prevention is largely reasons. They can lead to what we call medication overuse headache, and they can lead to other medical problems. Some of these medications that are used as rescue treatments are not always entirely benign. If with your family doctor says, I'm not, or they may be able to. About 20% of the time, I mentioned they get a diagnosis correct in the first time, but then they say, I don't know what this is. I'm going to send you to the neurologist. Then by the time you get to your neurologist, the headache is over with. Some people just skip the appointment altogether because they think, well, I'm better. And sometimes they get to the neurologist and say, well, you don't have the headaches anymore, so you're okay. And then that leads to this cycle of this recurring every time the headache comes back, delaying diagnosis quite significantly. So the abortive or rescue treatment that I mentioned, oral treatments are pretty limited for the reasons that I stated about improper absorption and the timing that people need. Nasal treatments can work, and inhalational treatments can work. So specifically oxygen. Oxygen has the highest level of evidence for treating something in the moment, and it has to be delivered properly. So it has to be by face mask. If there's holes in the mask, they should be plugged, and it has to be delivered at an adequate rate of at least 12 to 15 liters per minute. There is some evidence that even higher rates can help certain people who aren't responding to the rate of 12 to 15, but finding those specific attachments for oxygen containers can be tricky. But about 80% of people with cluster headache will have some relief within 15 minutes if the oxygen is delivered properly. Intranasal treatments, there's something called zolmitriptan that can be used. It has high quality evidence. The same thing with intranasal sumatriptan, a little bit less evidence, but still can be effective. Sometimes intranasal lidocaine can be used. And then we know that injectable treatments like sumatriptan can be quite effective. But unfortunately, using these kinds of treatments every single day for weeks and weeks or months and months at a time is simply not safe. The issues with oxygen, even though it probably is our safest and sometimes most effective treatment, is that it's hard to carry around. It's often not covered by insurance. And sometimes it may be used improperly, may not be getting the right rates. Sometimes they don't understand the kind of valves that you need to actually have the proper flow. And of course, in general, non-oral medications like nasal sprays, injectables, same reason. They're hard to carry around with you. They're hard to have at work, and they're often not as preferred. The truth is people want oral treatments. Sometimes, you know, ideally, I wish we had them. I wish we had more effective oral treatments than we do. Transitional treatments. So ones you'd use for episodic cluster headache, you'd use them for, you know, as soon as the headache starts, take them for a few weeks until it settles down, and then you may be able to come off of it. Sometimes oral steroids can work for that. There's some limited evidence for oral triptan medications, but my experience has been they don't work all that great. And then some poor evidence for some IV treatments. But one of the treatments that seems to be effective is occipital nerve blocks with steroid, or suboccipital steroid injections is the proper term that were used in the study. And delivering those at the onset of that cluster period can actually be quite helpful. And what's exciting is, for the first time in 30 years, there's a new approved treatment specifically for cluster headache, and that is a medication called galcanezumab that was originally designed as a migraine treatment, but at higher doses can actually help episodic cluster headache. Unfortunately, the trial for chronic cluster headache with this medication was not successful. When it comes to preventive treatment, some of these are messy. We know that verapamil can work, you know, for some people. Poorly tolerated in a lot of cases. Lithium can work for some people, and it's actually worked for some of my they're not problematic people, but people with the most problematic headaches that have not responded to a whole lot. Sometimes lithium has been a real savior, but it's messy, it's poorly tolerated. People don't like to be on it. Melatonin is good when it works. It's high dose melatonin sometimes can be appropriate as well. And at least it's well tolerated and quite safe. There are lots of others that get used in clinical practice, but there isn't as much evidence to support their use. It doesn't mean it won't work necessarily. It just means there's not always the same level of study. In terms of other options, so I have non-invasive vagal nerve stimulation listed as a preventive treatment. It's really more of an acute treatment, so this is a bit misplaced in the order. But it is a non-medicinal approach. So what it is it's a stimulator to what's called the vagus nerve that you actually stimulate on your neck during a cluster headache attack. And it has been shown to be effective for episodic cluster headache when it was compared with a sham treatment. So essentially a placebo instead of the actual stimulator. And then there are some surgical options that have been studied. However, the results are not always that fantastic. The one that seems to have the most evidence/safety profile would be something called occipital nerve stimulation. So some people may be candidates for this. Any surgical option should always be the last option after things have failed, because they often have less support by the evidence. There's a lot more risks associated with it, a lot more complications that can happen. And then some very invasive surgical options that are almost never recommended. There was some evidence mounting for a stimulator in the nose for something called the SPG ganglion in Europe, which showed some promise, but unfortunately the company that was making the stimulator is no longer operational. So the trial had to be halted. So hopefully one day that will start up again and we'll learn a little bit more about it. In terms of things that are coming up, we know that there is some mounting evidence for certain psychedelic substances, and this is certainly something I get asked about a lot. So psilocybin containing mushrooms or extracts from those mushrooms, there's some evidence in terms of case series and case reports and self-reports from people who have cluster headache who suggest that it can be effective. And the same thing with a substance that's a little bit like LSD, but not exactly like LSD. Usually the strategy is what we call microdosing, where you take it to the point where you actually don't get the hallucinogenic properties from it. There are some studies that are ongoing for this. Of course, this is not something that can be readily prescribed, and it's not something that we have a full safety profile on yet. So it's not something that's been widely recommended as of yet, but it may be in the future. And I think it does show some promise. So specifically, there's been reports of nearly 500 patients in support groups that suggest that people purport it to be more effective than standard treatments. So I think that's something that we need to take seriously, and all the more reason why we really need more studies to support, to really find out whether or not it's useful. But we really haven't seen the same kinds of reports of efficacy with things like cannabinoids like CBD and THC, and generally those are not recommended for use for cluster headache. Unfortunately, we have also seen that people with cluster headache seem to be at risk for drug use compared with people who don't have cluster headache. And the reason for that is unclear. Is it a coping mechanism because of the severe headaches they have, or is there some sort of perceived benefit that they're deriving from illicit drug use, or is there just something inherent that puts them at a higher risk for abuse and dependence? And I think that's another thing that is a really important thing we really need to learn more about. So what should people ask for when they have cluster headaches? So first of all, recognize that things can be cyclical. So it's important that keeping appointments, even if you feel well, to talk about what happened so that a proper diagnosis can be met. Making sure that you're taking note of how long attacks are and how often they occur. Try to figure out what time of day they occur and if there is some clear patterns to that. And then if they wake you up from sleep. And if you're not sure if you have these autonomic symptoms, even taking a photo of your eyes when you're at the peak pain to see if they look different can actually be quite helpful for your doctor. So there are lots of people who have skills and knowledge at treating migraine. For example, many primary care doctors are very, very excellent at treating migraine, but primary care doctors have simply less exposure to cluster headache, so they may not be fully aware. So ideally, you want to find someone who's somewhat of a headache specialist, or at very least a neurologist who has some experience with cluster headache to actually make the proper diagnosis. If someone is struggling with suicidal thoughts, substance abuse, it's always important to get help, whether they have cluster headache or not, of course, but that's an important thing to make sure you tell people if that's what you're dealing with. So with that said, I'm done with my content, and I think we have about 10 minutes for questions. So that was a lot of information I just sort of peppered at you.